I'll now talk about umbilical and paraumbilical hernias. These are the commonest types of hernias in the world. Here are some photos of umbilical and paraumbilical hernias. They may be present at birth or in childhood, and I won't discuss hernias in children, but mostly develop during adult life. Often they'll appear during a pregnancy in a young woman. They may be very small, totally asymptomatic, and are often an incidental finding. I will see an umbilical or paraumbilical hernia every couple of days, and patients referred to me for totally different conditions. Generally, in this situation, I often won't even inform the patient that they have one. However, if they're, for example, having a laparoscopic cholecystectomy for gallstones, I'll be making an incision at the umbilicus in any case to do their surgery, and will then recommend they have it repaired. Likewise, if they're having a laparoscopic repair of an inguinal hernia. But in general, small and asymptomatic paraumbilical and umbilical hernias we won't recommend repair. Having said that, there are some employers, in particular the Australian Defence Force and various mining companies, that will mandate repair for all their employees. I think this relates to the potential for great cost if the patient has to be airlifted from somewhere remotely. If someone has symptoms or the hernia is large, we'll normally recommend repair. The type of repair is determined by the size of the defect in the abdominal wall. Most umbilical and paraumbilical hernias are small. Many of them are able to be reduced. In other words, we can push the contents back into the abdominal cavity and feel the size of the defect directly. Some of them are irreducible. And if they're small, you can be sure that the defect is small also. If the hernia is large and irreducible, I'll often get an ultrasound or a CT scan to assess the size of the defect in the abdominal wall. This will also give added information with respect to the contents of the hernia. Small hernias generally contain extraperitoneal fat or part of the falciform or round ligament of the liver, and these are fatty structures. Larger hernias may contain omentum. This is the fatty apron that hangs off the stomach and sits in front of the rest of the abdominal cavity. And if they're large enough, they may also contain small or large bowel. With a very small defect of between 2 to 5 millimetres, it's reasonable just to close the defect with non-absorbable sutures. This was the way most small umbilical hernias were repaired in the past, and it's still a very reasonable approach for a very small hernia. This can be done under local anaesthetic if required, and in years gone by I've repaired some very small hernias in my rooms under local as an outpatient. The problem with putting in sutures is that usually the defect is round, and to close it with sutures, you're putting the sutures in the centre under tension, and it's possible for them to cut through. And I've seen occasions where umbilical or paraumbilical hernias were repaired with sutures. The hernia recurred, and when we went back in, there were 2 holes for each suture, and the defect resembled a daisy. If the defect is between 5 millimetres and 30 millimetres, we will normally do a repair with a piece of sublay mesh. In the past, some of these were repaired with inlay mesh, but often the mesh would become detached at one point of the defect and the hernia would recur. A number of companies have made some ingenious meshes for umbilical hernia repair. And here are some examples. The Design is the same. There's a smooth or an absorbable inner surface designed to prevent adhesions and a woven nylon outer surface. The mesh is folded in half, put through the defect into the abdominal cavity. The tabs are pulled upwards and sutured onto the edge of the defect, and the excess mesh is cut off so that the mesh is centred over the hole, secured centrally, and there's an overlap between the edge of the mesh and the edge of the hole, and it's under no tension. I think it's important to remove all the fat that's herniating through the defect before inserting the mesh. This procedure is usually done under a general anaesthetic as a day-case procedure in hospital. A small curved incision is made on the side of the hernia at the umbilicus to fit in with the umbilical contour. The hernial contents are excised, the mesh is inserted, and the wound closed in layers with subcuticular absorbable sutures and steri-strips to the skin. A long-acting local anaesthetic is instilled at the time, and intravenous antibiotics are given during the operation. It's quite a quick operation. Patients spend a few hours in hospital and are discharged. There is a waterproof dressing and we give them some oral analgesia. I think that this is a good operation and I've had it done on myself. I normally get the patients back for review about 7 to 10 days post-op, check their wound. I'll advise them to resume normal activities as soon as the limits of discomfort allow, and I get them back for a final post-op check at 6 weeks. The recurrence rate for this sort of a repair, in my hands at least, is less than 1%. I think I've probably put in 600 of these meshes in the umbilicus and have had 3 recurrences that I know of. I think in one case it was a technical issue in that when the mesh was inserted, one edge of the mesh had folded downwards and allowed fat to prolapse adjacent to the mesh. Another patient had a fall and I think tore the hole larger, and the whole mesh migrated up through the hole, which was now too large for the size of the mesh, and I'm not sure why the third one recurred. The risk factors for recurrence are the same as for the risk factors for recurrence in all hernias, namely they're more likely to recur in the obese or people that do heavy lifting. The other risk is if the wound gets infected, there's a risk of the underlying mesh getting infected. And I've had to remove 3 meshes following repair of umbilical or paraumbilical hernia. One of these had very bad dermatitis, and I think the mesh got infected with organisms from the skin at the time of insertion. Another one got infected when they got a wound seroma that discharged out through the wound, and then consequently organisms got in through the hole, and I'm not sure why the third one got infected. If the mesh gets infected, it nearly always will need to be removed to clean up the infection. Large umbilical or paraumbilical hernias more than 3 to 4 centimetres. Some of these are suitable for repair with the largest size of these meshes. What I will normally do in this case is insert a non-absorbable purse string suture to narrow the hole somewhat after the mesh is inserted and put in some extra stitches. But if the hole is bigger than 5 centimetres, I think these need to be treated like ventral or incisional hernias and are probably best repaired laparoscopically. And I'll talk about these types of hernias subsequently.